Welcome to our Medicaid Performance Year 2026 Tier I Quality Measures training. In this course, we'll walk through each Tier I measure, discuss documentation expectations, and outline workflows that improve performance across our network. This training is designed to give you clarity, confidence, and practical steps you can apply immediately in your day-to-day work. By the end of this module, you'll be able to define each Performance Year 2026 Tier I quality measure, identify who counts toward each denominator, and understand the documentation and coding requirements that determine successful numerator capture. We'll also walk through efficient workflows that help close gaps and review common errors that can cause missed opportunities. Let's begin with our adult measures. These measures evaluate adherence, chronic condition management, and preventive screening, all areas where clear documentation and strong care coordination make a measurable difference. AM, adherence to antipsychotic medications for individuals with schizophrenia, looks at members 18 and older with schizophrenia or schizoaffective disorder who are prescribed antipsychotic medications. To meet the measure, members need a proportion of days covered of 80% or more across the entire measurement year. Long-acting injectables count, and the measurement window runs from January 1st to December 31st, 2026. Pharmacy claims across the full year determine adherence, so capturing medication changes and long-acting injectable administrations is essential. To support adherence, staff should consistently verify medication use during every touchpoint, whether that's the front desk confirming refills, medical assistants reviewing missed doses, or providers considering long-acting injectables when adherence is low. Care coordinators play a key role by synchronizing refills, scheduling 90-day supplies when appropriate, and conducting monthly outreach for at-risk members. For documentation, always complete medication reconciliation, keep active medication lists updated, and accurately record long-acting injectable administrations. Patient-reported fills from external pharmacies should be documented clearly. AMR, asthma medication ratio, applies to members ages 5 through 64 with persistent asthma. The measure calculates the ratio of controller medications to total asthma medications, and members need a ratio of 0.50 or higher. The measure uses both current and prior year events to confirm persistent asthma, and pharmacy claims across the full measurement year determine compliance. During visits, ensure symptoms, inhaler use, and control level are documented. If members use rescue inhalers more than twice per week, consider step-up therapy. Care coordinators should follow up at 30, 60, and 90-day intervals to support refill adherence. Documentation must include inhaler technique education, updated asthma action plans, and clearly labeled severity and persistence on the problem list. CCSE, cervical cancer screening, includes members aged 21 to 64 with a cervix. A member meets the measure if they have a Pap test within the last 3 years, a primary high-risk HPV test within the last 5 years, or a co-test within the last 5 years. The look-back period depends entirely on the screening type performed. To improve CCS performance, always flag gaps during rooming and prepare supplies for same-day Pap or self-collected HPV when appropriate. Providers should offer screenings even during non-preventive visits if clinically appropriate. Outreach should be culturally and linguistically appropriate, especially for populations with historically lower screening rates. Make sure Pap and HPV results are recorded in discrete lab fields and import or correctly scan external results. If a patient has had a hysterectomy with no residual cervix, document it clearly, because this qualifies as an exclusion if worded appropriately. PPC1. Timeliness of prenatal care includes pregnant members whose deliveries occur between October 8, 2025 and October 7, 2026. Members must receive a prenatal visit either during the first trimester or within 42 days of enrollment. Correctly identifying the pregnancy early and scheduling timely care are critical to meeting this measure. The first prenatal appointment should be prioritized. Intake documentation must capture pregnancy details such as last menstrual period, estimated due date, and gestational age. Providers should complete full assessments, document counseling, and ensure OB handoffs are clearly recorded. Avoid relying solely on global obstetric codes unless the date of the first prenatal visit is clearly documented. Next, let's review transitional care and readmission measures. These require rapid follow-up, real-time coordination, and strong communication between care teams. The PCR, Plan All-Cause Readmissions measure, looks at members discharged from acute inpatient hospital stays and evaluates whether they are readmitted within 30 days. Planned admissions, like labor and delivery, are generally excluded. The rate is risk-adjusted, using an observed to expected ratio. To perform well on PCR, timely follow-up after discharge is essential. Daily review of discharge lists, proactive outreach within 48 to 72 hours, and thorough medication reconciliation help prevent complications. Documentation should include confirmation of patient engagement, discharge details received, medication reconciliation performed, and a PCP follow-up visit within 7 days. Barriers such as transportation or medication access should also be discussed and documented. Now let's shift to pediatric quality measures. These measures reflect early childhood wellness, developmental monitoring, and preventive care throughout adolescence. The 30A, Well Child Visits in the first 15 months includes infants from birth through 15 months of age. To meet the measure, each child must complete at least 6 Well Child visits before their 15-month birthday. These visits are foundational for growth monitoring, early developmental screening, and immunizations. For infants in their first 15 months, staying ahead of the Well Child schedule is critical. Pre-scheduling all upcoming visits helps families stay on track, and when a child misses an appointment, outreach within 48 hours ensures the care plan doesn't fall behind. During each visit, make sure your documentation includes the child's medical and family history, a thorough physical exam, developmental surveillance, and accurate growth parameters. Don't forget anticipatory guidance and immunizations. These are required components for a valid numerator hit. By keeping visits scheduled, converting sick visits when appropriate, and documenting all required elements in structured fields, we can consistently meet the W30A measure and support healthy early development. AU30B Well Child Visits. 15-30 months applies to children 15 to 30 months old and requires at least 2 Well Child visits during this period. These visits support developmental screening during a critical stage for language and social development. Just like the W30A measure, pre-scheduling is key. Pre-scheduling upcoming visits, such as the 18, 24, and 30-month checks, helps families stay aligned with the recommended schedule. When possible, converting a sick visit into a well child encounter can prevent missed opportunities and keep the child compliant with the measure. During the visit, make sure documentation is thorough and includes the core elements required for a valid numerator. That means a complete physical exam, age-appropriate developmental screening such as the ASQ or the MCHAT, updated height, weight, and BMI, and anticipatory guidance. Clear, structured documentation ensures the visit counts, supports early developmental monitoring, and strengthens overall pediatric quality performance. The WCV Annual Child and Adolescent Well Care Visits measure applies to members ages 3 through 21 and requires at least 1 annual well care visit each measurement year. This visit includes developmental, behavioral, and physical health assessments. The WCV workflow starts at intake. Make sure gaps are identified early, confirm immunization status, and prepare any age-appropriate screenings or counseling materials needed for the visit. Providers should complete a full preventive exam and ensure documentation reflects all required elements. a thorough physical exam, a complete medical and developmental history, both physical and mental, and counseling on nutrition and physical activity. Height, weight, and BMI percentile must also be entered using structured fields. Because adolescents have the highest rate of missed visits, targeted outreach is essential. Use recall campaigns, community health worker outreach, and flexible scheduling options to help families complete the annual visit. Accurate, structured documentation not only ensures the visit counts, it also supports early intervention and reinforces continuity of care throughout childhood and adolescence. Before we wrap up, let's take a step back and look at all measurement year 2026 Tier I measures together. Understanding the timing, measure type, and look-back period for each measure is essential because these details drive how we plan outreach, documentation, and operational workflows across the entire year. AAM and AMR are full-year pharmacy measures. That means they rely entirely on clean, accurate, and timely pharmacy claims from January 1st through December 31st. Because these measures reflect behaviors and medication access over a long period, any delays in medication reconciliation, refill syncing, or proactive outreach can have a direct impact on performance. CCS, on the other hand, uses a multi-year look-back period. Depending on the test type, we're looking for screenings within the last 3 or 5 years. This means the opportunity window is broad, but it also makes documentation accuracy even more critical. If a PAP or HR-HPV test was done at an outside facility and we don't import the result correctly, the gap will appear open even when the member is actually compliant. Tight documentation practices make all the difference here. For prenatal care, PPC1 has a very narrow window. Members must receive prenatal care either in the first trimester or within 42 days of enrollment. Because this window is so short, workflows need to support rapid identification of pregnancy, fast scheduling, and precise documentation. Delays of even a week can mean the difference between meeting or missing the measure. PCR, our readmission measure, uses a 30-day follow-up period after discharge. This is where timely ADT alerts, rapid outreach, and clear communication between inpatient and outpatient teams become crucial. Transitional care work must happen quickly, ideally within the first 48 to 72 hours after discharge, to prevent complications and reduce avoidable readmissions. Finally, our pediatric measures, W30A, W30B, and WCV, are tied to age-specific visit milestones or annual well-care expectations. These measures depend heavily on scheduling discipline, visit conversions, and complete documentation of well-child elements. Because pediatric visits often stack around specific age checkpoints, structured workflows and recall systems help maintain compliance. When you look at all these measures together, one theme becomes clear. The timing of documentation and outreach matters just as much as the documentation itself. Understanding the measure windows ensures that our workflows are proactive, not reactive, and that we're capturing every valid opportunity to support our patients and our performance goals. To strengthen performance across all measures, close care gaps early, use discrete structured fields when documenting, and encourage timely labs and screenings. Improve visit conversion opportunities, support medication adherence, and complete transition of care outreach within 48 to 72 hours. Consistent outreach and panel management remain some of the most effective strategies for quality improvement. Thank you for your commitment to delivering high-quality care and supporting our value-based performance goals. Your commitment to accurate documentation, timely outreach, and patient-centered workflows directly contributes to better outcomes for our members and stronger performance across our value-based contracts. If you have questions about any of the measures we covered today, need help interpreting documentation requirements, or would like support refining your clinic's workflows, please reach out to Kimberly Gonzalez at kgonzalez@asbestcare.org for guidance, resources, or hands-on support.